Next talk will be on behalf of Dr. طارق عبد الرازق. دكتور طارق ربنا يديله الصحة، اعتذر، ندعو له بالسلامة إن شاء الله. واي طارق IOLs دكتور طارق عبد الرازق، واللي هيقدمها عنه دكتور أحمد المصري.
بسم الله الرحمن الرحيم. ليا الشرف كالعادة أن أكون دايما في مؤتمر الصفوة زي كل سنة، ونتمنى دائما النجاح. وبشكر طبعا دكتور سعيد جمعة ودكتور أشرف شراوي دعوتهم الكريمة لينا أن نمسك السيشن بتاع الكاتريك. الدكتور طارق عبد الرازق ربنا يشفيه، والحمد لله هو كويس الحمد لله، بس ما قدرش ان هو يجي طبعا. فانا المحاضره دي بالكامل عن لسان الدكتور طارق، وفيها بس سلايد واحده بتاعت اللي هي النوموجرام بتاع الاوبوزيت كلير كورنر انسيجن، زودتها في النص. المحاضره از فيري بيزك، بنتكلم مينلي عن الاسtigmatism. And definitely the astigmatism has a role in improvement of both the cataract surgical techniques and technologies, and that's because the patient's demands are now very high and they need their spectacle independence. All of us know that the astigmatism constitutes about 15 to 20% of our population, which is more than 1.5 diopter of astigmatism. So this presentation will cover an overview about the astigmatism and its types, and how to diagnose and how to measure corneal astigmatism, and then how to treat the astigmatism with its history and the recent advances. Of course, all of us know that astigmatism means A means no, and stigma means a point, means without a point, which is a Greek word, and this represents the retinal image without astigmatism, and this is with the astigmatism, and simply it results in blurred image due to non-sphericity or irregularity of the optical system, whether in the cornea or in the lens or both. And this is our main issue, to know whether the astigmatism is mainly in the cornea to be totally treated, or part of it is in the lens that could be avoided, and what's recently the role of the posterior surface of the cornea, and what's its relation to the post-refractive surgery, and all these issues. So as we all know, basically that we have types of astigmatism, which are whether corneal or lenticular, and the corneal with the rule, which means the vertical diameter is more curved than the horizontal one, and the lenticular is mainly in the lens itself, and the corneal one, which is most relevant for the cataract surgery, but when the crystalline lens is removed. Again, it is classified, as you all know, whether it is a regular or an irregular astigmatism, and simply the regular astigmatism means each steep and flat meridia are 90 degrees apart, whether myopic, hyperopic, compound myopic, compound hyperopic, mixed. And the regular astigmatism, the difference between the vertical and the horizontal diameters, they are not 90 degrees exactly apart, and this is very common in cases of keratoconus if it is from the corneal side, or in the lenticonus if it is from the lenticular side. Again, with the rule astigmatism, there's the minus axis at 180 degrees and the plus axis at 90 degrees. Again, the rule is the opposite. And these are all basic concepts and basic facts about the astigmatism. Then how to diagnose it? Simply with the autorefractometer and the refraction with the retinoscopy. And of course, whether the refractometer with keratometer, that you know that if the Myers are a little bit not regular, put in mind that this patient may have keratoconus, and you have to do topography or a further diagnosis to know whether the patient is keratoconic or not, especially in patients with aborted keratoconus in old age with cataract, which is really a dilemma how to treat these patients to have a good refraction after the surgery. Subjective refraction includes both the corneal and lenticular astigmatism. For cataract surgery, we are concerned only with the corneal element, not the lenticular element, but we have to differentiate between either it is corneal or lenticular, and the recent machines like the eye tracing has a role to distinguish between the corneal and the lenticular, as we are going to see in my presentation about the eye tracing with the trifocals. How to measure the corneal astigmatism? Simply, we know that the astigmatism is influencing the clarity of vision and the blurring vision, and here how much is the uncorrected visual acuity is affected with the degree of astigmatism, whether it is less than 1 or more than 1. And this is the picture whether the patient has one diopter or two diopters of astigmatism. And these are some papers concluding that one diopter of astigmatism has a role in the quality of vision. And again, this is an important point when you are putting a toric IOL. Don't tell the patient will be free from astigmatism. But our aim is to decrease the astigmatism to less than 1. 0.75 is acceptable, 0.5 is acceptable, because I'm telling the patient that the quality of vision differs with the astigmatism less than 1. It is more than 1, he is a little bit annoyed. So because when you have a perfect surgery with just half a diopter of astigmatism after toric IOL, the patient says, why I still have half a diopter? But when you tell him before the surgery that up to 1 diopter is accepted after the toric IOL, and this, of course, Dr. Ala Izzawi is going to talk about it in details. Again, how to treat the astigmatism. We have history and the incisional surgery, the laser, and we leave the toric IOL for Dr. Ala Izzawi. And this is simply Dr. Tariq is trying to present the history of how to treat astigmatism, starting with Satou on 1936 with its incisions, then the Vidroff with the famous radial keratotomy that had a long time of maybe started in 1969, and of course all of you know the Perk study of after 10 years of radial keratotomy that more than 80% they had regression, but the idea was nice. But now there is no role for radial keratotomy or incisional surgery most of the time, and the excimer laser correction and the femto laser, they have a role in correction of the astigmatism now. Regarding the incisional surgery, depending on the biomechanical response of the cornea to the surgical incisions and the coupling effect of the one meridian to the other one, we can do incisional surgery to correct the astigmatism, which of course of a low cost, because all what you need is diamond knife, but has the disadvantage of less accuracy because of the different nomograms and the different response of the cornea, and the correction usually is not optimum, and when it is optimum, there is a marked regression. And of course, it is contraindicated in patients like severe dry eye, corneal disease, and patients with glaucoma and retinal detachment. So there are different names of these peripheral corneal incisions, and I'm interested in the opposite clear corneal incision more than the others, which is still not up till now. It has a role, and I took the chance from Dr. Tariq to present this simple predictable nomogram that may be benefit of you to use it when we open 3 millimeter clear corneal incision with another opposite clear corneal incision. We improve 1.86 diopter of correction if you are 1 millimeter from the limbus. And if this same 3 millimeter keratom incision became 2 millimeter from the limbus more to the center, it improves 2 diopters of astigmatism. And if it is 3.2, which is a wider, which is, don't forget, in cases of ICL, that many patients, they have astigmatism that could be corrected with the opening on the steep meridian and on the opposite clear corneal incision. If you reach 3.2 millimeter, 1 millimeter from the limbus, it corrects up to 2.25 diopter of astigmatism. And if you reach 2 millimeter from the limbus with 3.2 millimeter keratome, it corrects up to 2.5 diopter of astigmatism. This was a doctor thesis that had been published since 2014, and up till now, definitely it helps me. And if you have less astigmatism, when you open on the steep meridian, you definitely correct at least 0.75 diopter, which is, of course, especially for the trifocals, is forgiving for the trifocal IOLs to have astigmatism less than half a diopter. Again, the limb relaxing incisions also using the diamond knives have role in the correction of astigmatism, but as we said before, it is usually not long lasting because there is marked regression and there are different nomograms for correction of astigmatism in these patients. But I know that most of us are avoiding the limb relaxing incisions because of the presence of the toric IOL or the opposite clear corneal incision. Again, as we said, the main problems from this incisional surgery is the perforation, but the advantage of the clear corneal incision with the opposite, it is a full thickness incision, not partial incision. That's why it is more long lasting than the other incisional surgery for correction of astigmatism. Laser surgery, as we said before, now is the modern surgery, of course, for correction of astigmatism. As you all know, whether the remnants of cylinder after the cataract surgery or in highly demanding patients that they want to get rid of what's remaining of the astigmatism by or the cylinder, and it has the advantage of the precision, and it had been evidence-based, as Dr. Ala said, the reproducibility of the laser surgery in correction of astigmatism, as you all know, whether it's topo-guided or wavefront guided, and taking care of the crystalline lens, and if there is any role of the lens in this case, because we are just correcting the corneal astigmatism. Lastly, the toric IOLs, and here I'm going to stop, if you don't mind, to allow Dr. Ala Zawawi to speak about his talk about the toric intraocular lenses and the role in the correction of astigmatism and why toric IOL. Thank you so much.